This week on the BackTable podcast.
Other than internal review, external review, and coming back to the insurer, nothing else has been demonstrated to be significantly successful or cost-effective, because one can make a full-time occupation out of this. And as it is, most offices have had to demonstrate significant resources in this process. And it's physician time and it's other FTEs that have to commit to the process. And it really just adds to the cost and complexity of the care.
Hi, everybody. Welcome to the BackTable ENT podcast. We're a podcast that focuses on all things otolaryngology, and we've got a really great show for you today. Thanks for stopping by. Now, a quick word from our sponsor. Stryker's ENT solutions offer the control you need, the flexibility you want, and enable you to deliver the experience your patients deserve. With Stryker, you gain access to the most complete suite of solutions to help make your vision of patient care a reality. From technology to training, from reimbursement tools to patient education, Stryker is there to help. Together with their customers, they are driven to make healthcare better. Learn more at ent.stryker.com. Now, back to the show. I'm Ashley Agan. I will be your host today, and I am joined by Dr. Gavin Setzen today. Welcome to the show, Dr. Setzen.
Thank you very much, Dr. Agan. A pleasure to be here and looking forward to a great conversation.
Me too. Let me give you a proper introduction for our listeners who don't already know you. Dr. Gavin Setzen obtained his medical degree in Johannesburg, South Africa. And after spending 2.5 years in general surgery at Cornell University Medical College, he completed a 5-year residency in otolaryngology at Albany Medical Center in Albany, New York. He is a diplomat of the American Board of Otolaryngology Head and Neck Surgery. He's been an active member in numerous societies, including serving as past president of the American Academy of Otolaryngology Head and Neck Surgery, past chair of the Board of Governors of the American Academy of Otolaryngology. Today, we're going to talk about navigating the complexities of health insurance plans from the physician practice side of it. The patient side of it would be a whole other podcast. So from the physician side of it, how to navigate health insurance. So it's going to be a really good conversation. Gavin, fill in the gaps. Tell us more about yourself, your practice, your history with Albany ENT.
Thank you very much, Ashley. So I was born in Johannesburg, South Africa, and went to med school in South Africa. I emigrated and arrived in New York in January of 1990 via Moosomin, Saskatchewan, where I worked as a GP while waiting for my green card, and that was a very interesting experience. And, as you alluded to, did half a general surgery residency, followed by my Odo residency up in Albany. I had a strong interest in general otolaryngology and pursuing a career in independent private practice, and took over the practice of a solo otolaryngologist who had developed a busy allergy practice, skin testing, immunotherapy, and the like, a busy rhinology practice, and interestingly, a state pedectomy practice. So I took over his practice and over time grew the practice. We've remained independent. We are currently a 9-physician, soon to be 10, 18 PA practice. We're in 2 locations. We have a large primary office, 54,000 square feet with an ASC, and a walk-in ENT urgent care, etc. We provide general odo care, specialty care, and the like, and have had a long history in organized medicine with the Academy and other entities. And that has helped inform my experience and exposure on the payer side and the patient journey, and certainly, especially today, interested in the patient journey, the patient experience, cost of care, how we can move that needle, improve access, and continue to provide great auto care for our patients and ensure the preservation of our specialty. So that's a little bit of my journey and passion for the things that you and I and those listening do every day.
Yeah. And you've been in the game for a long time. I'm sure you've seen a lot of changes along the way. And just to kind of set the stage for our conversation, can we just kind of talk about the current healthcare landscape and, some of the challenges that are being faced by different employment models, what reimbursement's looking like, what are some of the challenges in private practice?
Certainly, and I think that's a great context to frame the discussion, because as we've all experienced in our daily practices, the challenges of care provision continue to increase, and it is no longer siloed to private practice or academic practice. I think the challenges are equally significant in each of these environments, and I think maybe even more so having emerged from the fog of war, the coronavirus pandemic, which had a profound impact on healthcare. So, we live in an environment where reimbursement continues to decline. The cost of care provision continues to increase, and medical inflation from the care provision side of the equation is really consistently increasing and not keeping up with reimbursement, or reimbursement is certainly not keeping up with medical cost of care. What we're all preparing for is potentially a 3.37% Medicare cut. This is a sum zero game. So, when there are cuts, they usually come out of the surgical pool, and surgeons are disproportionately impacted. So we are all bracing for those changes despite advocacy. Coming out of the pandemic, the cost of labor, availability, and cost of supplies has been problematic. There's decreased access to affordable or cheap capital. We're in a high interest, high inflation environment. And consistent with all of that, we've all seen a lot of consolidation in the healthcare industry. And whether it's on the payer side, which is a new development, you look at the Optums of the world and United Healthcare. Optum employs over 70,000 physicians. Optum Care provides care for more than 20 million Americans. So the care paradigms are changing. We've got all these non-traditional players coming into the market, the Amazons, the Walgreens, the CVS. And while they're starting out in more primary care type environments, they're helping to redirect referrals and changing referral patterns, and employers are deciding who can have surgery where. So you couple that with 10,000 Medicare entrants into the program on a daily basis in an aging society, and what the Medicare, Medicaid reimbursement looks like, and the number of non-traditional challenges that we have. There are less commercially insured patients out there, and I think all of this sets the stage for a more complicated process where we are now required, I think, to be more mindful of how to navigate the insurance environment and how we can help advocate for our patients, and in so doing, ourselves and our practices, both academic and private, to be able to sustain and potentially, stay independent if that's the preference, because I alluded to, high merger acquisition environment, private equity environment, which is also permeating the academic environment as we see consolidation there too. So that's just a little bit of the lens through which I look at the current environment.
Yeah, it gets really complicated really fast, and just needing to know all the different rules for different payers, and have, if you're taking patients with all different types of, insurance and payment types. And it can be really complicated for the solo private practice. You could spend a lot of time each day just trying to make sure that you're jumping through the right hoops and checking the right boxes. So in ENT, we work with a lot of technology. There's new devices coming out all the time for different procedures to be able to offer patients. And talk to me about kind of the interplay of being able to take a new technology, something new comes to the market and it offers potentially a lot of patient benefit, and how that is able to, come into your everyday practice, knowing everything that you just told us about the complexities of how reimbursement work.
Thank you, Ashley. And I think that's an important perspective, because we have to, in advocating for our patients to get new drug and device and other interventions approved, be doing so working closely with drug and device manufacturers and the R&D side. It's a very complex process. It's a very costly, time-consuming process. There was something of a lull in terms of the amount of ENT interest and support in helping to facilitate that process. By virtue of the things that we see and do every day, a lot of our organic growth and the things that we do is facilitated by the fact that we can do lots of different procedures now in office, in a lower cost environment and setting that have high degrees of efficacy and improve the patient journey and the patient outcome. And so to be able to facilitate that, we have to be cognizant of what it takes to bring products to market and to be able to support that journey. I think, embarking on the commercialization process is a very long, very costly process, whether it's the FDA approval process, just developing lead generation, for example, leveraging market research and outreach efforts, whether it's with stakeholders, insurers, physicians, trying to develop the market, developing key opinion leaders, facilitating training, education, developing these partnerships to help bring a product to market. I think when you peel back the layers and what's required to do that, value analysis committees, FDA clearance, CPT coding and validation, involvement of group purchasing organizations, physician adoption, pricing of unit definition, marketing, replacement considerations, insurance and value assessments. There are just a multitude of processes. They are very time consuming, not to mention the clinical trial journey. And so these are tens of millions and in some cases hundreds of millions of dollars in order to bring drug and device to the market and for commercialization. And so I think we have to be cognizant of that. I think physicians have an important role to play in that, ensuring integrity of the process and ensuring patient safety and optimal outcomes. And so when these drugs and devices come to market and we have an opportunity to participate in clinical trials, I think that is a very exciting part of what we all do on a daily basis and have the opportunity to participate in these, to lead the edge in terms of defining new technology and drugs in our field. And that's a very robust process, and our field lends itself to that. So I think, what we have to do is support the process, look to other stakeholders. Once that technology, for example, has come to pass, you look at the complexities of the new codes for 2024, for example, radio frequency for Clarifex, these new entrants into the market, and you look at the Strykers, the Aarons, the Neurons, the There's a host of different players bringing these opportunities to market. And one of the challenges is obviously on the FDA side, but then certainly AMA and CPT to have a coding process that's robust and meaningful, that you can bring codes to the market for utilization. The challenge there is, as we all know, these codes were introduced in 2024, and while Medicare and certain commercial carriers will carry them and pay these procedures, a lot of the commercial carriers will introduce the code and based on demand and utilization will revert back to investigational and experimental. And so that leaves the physician and the patient in a very challenging position, because one might have been providing that service for a short period of time and then it's denied. And so from a care provision aspect and then the complexities of the working mechanisms, revenue cycle management, approvals process, prior auths, all the mechanics in the back office become that much more complex as well.
Yeah. And I want to get into that. But before we do, you listed the long list of things that have to happen for a product to kind of finally be able to be, consistently used for patients. What's a typical timeline to be able to accomplish all of those steps?
So, that is anything from 2 to 5 years, depending on the technology, drug device, and again, tens of millions of dollars, if not more so, and a very complicated process. The other thing is, in terms of the clinical trials, most studies today, prospective, randomized, double-blinded, etc., pivotal trials, and what the FDA and the insurers are looking for are obviously safety, efficacy, but durability as well. And for all the procedures that I mentioned earlier, we have that. We have the durability as well. We have 24-month plus data. We have post-market surveillance. And the frustrating part from the otolaryngologist's perspective and similarly from the patient's perspective is a lot of the insurance determinations become arbitrary. So while the FDA asks for these things and then adheres to them, on the insurance industry side, particularly with commercial payers, these arbitrary decisions will change their determination. And, what we commonly see is things being re-identified or classified as investigational and experimental. And that completely limits the patient's access to a technology or treatment that we know to be safe, effective, and durable, that has been demonstrated in multiple studies. And so, patients are always asking, well, what does that mean? Where does that leave me? What are my options? And the perplexing and frustrating part of this is that the alternatives are more costly procedures that are more invasive, performed in hospital outpatient or other settings under general anesthesia. And it really ignores the patient journey experience and completely defies the logic in terms of the cost of care when you look at the episodes of care and our ability to bend the cost curve in a favorable position. And so, when you try and explain to a patient investigational and experimental for a drug device procedure intervention is something not yet proven to be medically safe and or effective or not medically necessary as per the verbiage of the insurer, that puts us in a very difficult position because it looks like we're advocating unsafe technologies and treatments and that it's not medically necessary, and we're advocating for that too. And I think morally and ethically, it puts us in a challenging position and casts a negative perception in the patient's eyes, while all of that data obviously exists and is used around the country in thousands of patients with good outcomes.
Yeah. Yeah, I could see how that would be really confusing from the patient's standpoint. If you've gone through everything, you recommend a certain treatment, and then their insurance comes back and says, "Oh, that's experimental. Like that's not safe." So what do you do at that point? Let's talk a little bit about establishing medical necessity and prior authorizations. Are there things that you do in your practice to kind of help to be able to, get things approved?
Sure. And I think that's the important consideration, is how do we suit up and develop these processes? Medical economics in 2022 reported that physicians spend 40% of physicians, spend 1 to 9 hours a week on the prior authorization process. In an era of physician burnout and fatigue and cost constraints and economic challenges and so on, it's difficult enough providing the care in general. So I think developing a process in one's own practice where the back office has been educated and trained and is familiar with the procedures and technologies that we are advocating for, that each individual insurer that one participates with, we are familiar with their coverage policies and determinations, so that we can develop a proactive position to advocate for the patient when we know they need a particular intervention. And so that requires involvement of the revenue cycle management team, nursing staff. Most of ENT practices, both academic and private, have dedicated staff committed to the prior authorization process and what that looks like. And I think one has to have a very clear mechanism established to do that, recognizing that this is part of the landscape, but it's not a luxury anymore, it's a necessity. And so from the physician's point of view, documentation in the medical record is essential. Telling the patient's story and making the case for medical necessity. And I think the better we do that, and sometimes a procedure is denied because there was no explicit discussion about prior use of intranasal steroids, for example. So it can be very simple and elementary through no matter what story you tell and how reasonable and medically justifiable your recommendation is, it is determined to be investigational and experimental. So I think having a frank conversation with patients, educating patients about their treatment options and the challenges is important, because we tell patients that, there is a prior authorization process. We will help you through that journey. But as a consumer, in an era of medical consumerism, we onboard that patient in the process. We have that patient reach out directly to their insurer. They write letters to their insurance company and they copy their primary care physician and any other physicians that they are seeing. We have them copy the state insurance commissioner and any other entity that we feel is reasonable relative to that particular claim. And the insurers don't like negative publicity and noise, and the more of that we can do in advocating on behalf of the patient, the better. We do the same thing. We will reach out directly. We will request external or internal review to begin with, because the typical process is a non-physician reviews the initial submission criteria, and a nurse or other allied medical person is looking at a checklist on a computer screen.
And that's within the insurance company side of it, correct?
Correct.
Yeah.
And so they don't have the clinical expertise from an otolaryngology perspective or the nuances to be able to differentiate what seems reasonable. So certainly an internal review process is one option, but certainly if that is unsuccessful, and each of these takes time, personnel, resources, invariably it is difficult to schedule these, and you have to call yourself as the physician. So you're out of your clinical setting, trying to make phone calls. You're speaking to a non-otolaryngologist who has not reviewed your detailed medical record, and it becomes enormously frustrating. And I will say that oftentimes, whether it's requesting a treatment approval or a diagnostic CT, having had the conversation in a reasonable fashion, you do get approval. Now, obviously, for the newer technologies and things like that, it's more difficult. And it's interesting. My experience is the first thing I'll ask the physician reviewer is, what is your impression after review of the medical records that I sent you? And the vast majority of them have not reviewed them or did not have access to them. And so it's very hard to challenge the physician on the line when they've not done that. And I find that very helpful, almost shaming the reviewer into the approval. And so when that fails, and some companies do not offer the option of an internal review and you have to go to external review. And it varies widely by insurer, by region, etc. And so what else do we do? And what else do I recommend is bring in other advocates. The American Academy of Otolaryngology Head and Neck Surgery, position statements, clinical practice guidelines, clinical consensus statements, extraordinarily helpful. Other specialty societies, the American Rhinologic Society, position statements, AAOA. So scientific documentation for outcome, safety, efficacy, durability, etc. Anything that we can do in that regard. Then, for example, in New York State, no legislation changes without the involvement of the New York State Society, the Medical Society. So we advocate closely with the Medical Society of the State of New York, the New York State Society of Otolaryngology Head and Neck Surgeons. We bring in other medical entities. And so building coalitions to try and help advocate can also be very helpful as it relates to moving patient issues forward. And then I think we live in an era where I referred to medical consumerism earlier. And when you consider that patients are paying higher copays, higher deductibles, more patient responsibility and out-of-pocket care, so is that the case for the employer. And in an employer-funded healthcare environment, the employers are having a greater say in dictating technology, treatment, site of care. For example, Walmart will tell you where you can have your coronary artery bypass or your hip replacement. And so we have patients reach out to their employer, and the employer gets involved in the process. We've had great success using, in upstate New York, patient unions, and we were able to get sublingual immunotherapy covered for 12 years by involving the unions. And I think one has to be fairly creative in terms of who can you involve in the process advocating for the patient. And that includes the state health insurance commissioner, who can be a great advocate as well, because it's a consumer protection at the end of the day.
Yeah. So there's power in numbers. I talked to Dr. Pete Maness about advocacy recently. So that podcast will be up soon. And we talked a lot about the resources that the Academy has with the position statements and, bringing patients in to kind of help with that advocacy, when you're asking your patients to reach out to their insurance companies, do you give them, a template to start with? Like, do you make it easy for them to kind of, do that as far as like, here's a general template of like kind of the things you need to make sure you tell them or ask for. And, here, you should include, the people that you just mentioned as far as like the, CC your primary care doctor and, all these others. Like, do you kind of help the patient along the way as opposed to just kind of giving them homework?
Absolutely. That's a good point, because the patients are fairly fatigued in the process too. Just the annual insurance review and the processes that the patient has to go through are equally complex and confounding and frustrating. And, they are having issues with prescriptions on a daily basis, much less procedures. And so we have information that we provide to payers based on the carrier. We provide additional access to resources, including clinical data. And we, document patient experience, whether positive or negative, in terms of their outreach. And so, we develop a little bit of a database of experience with individual procedures and technologies and drugs for individual carriers. I think another thing that I would recommend in the patient journey is explaining to patients that this is a time-consuming process, but that in a collaborative fashion between the patient and their resources and access to the employer and their legislative representatives and others, we can get this done. And, Tip O'Neill always said that all politics is local. I think the same can be said for the insurance environment. While Medicare and Medicaid, federal programs are generally easier to work with and provide greater coverage optionality, at the local level, developing relationships that are meaningful with local insurers and working on those relationships, meeting with insurance medical directors and others, has definitely provided significant benefit in our practice. And for example, with one of the largest payers in upstate New York, we've had meetings where we've been able to reverse experimental and investigational determinations based on reasonable conversations, demonstrating the clinical trials, safety, efficacy, and durability. Durability is what they continuously look for, despite having 24-month plus data, and making the economic argument. So we've had a lot of success making the economic argument today that using a bioabsorbable implant or a radio frequency technology performed under local anesthetic in a medical office is orders of magnitude less costly than a similar procedure being performed in an ambulatory surgery center or an HOPD or hospital OR, and orders of magnitude less than the alternatives, for example, open rhinoplasty, spreader grafts, or whatever more expansive surgical alternatives there are. And when you can make that argument to a employer-based insurance policy person, when you can demonstrate earlier return to work with less morbidity, the employer and the patient value that substantially. A lot of patients in the current work environment are afraid to take time out of their work schedule to do a surgery because they are at risk. So I think making the economic argument is very important as well.
For sure. It makes sense. It seems like that would be a no-brainer if something, could give you the same outcomes but be much less expensive. You would think that would be a pretty easy ask. When you're having these conversations, so are you specifically the person who's going in and requesting meetings and, trying to negotiate and advocate for these procedures? Like, how do you have time to do that? And how does that look? And how quickly do you see a change in the policies?
So that's a very good question, because we are all challenged on a time perspective. Physicians have a certain amount of time in any given day, and the regulatory and other challenges and demands on our time continue to increase. So we have, as part of our revenue cycle management team, prior auth team, folks who do a lot of the outreach to the insurers to do the preliminary work in determining what the issues are and what the ask of the insurance company is in terms of helping to move the process forward. They will look at what the patient journey has been thus far, whether there was an internal review or an independent medical review, etc. We will typically do that for a variety of different medical and surgical interventions. Once we have a good historic database about what that all looks like, I would typically reach out to a medical director at one or more of our local regional insurers, and oftentimes, it's a virtual meeting with a national entity. And I think in a face-to-face environment where you've established relationships over many years, it's much more persuasive making the argument and demonstrating the data and demonstrating support from organized medicine, academia, and other entities. We find that we can be very successful in overturning investigational and experimental determinations. We were able to do that for Latera and some of the RF issues, and we're working on that process right now. But again, it does require time and effort, and I think we are required to do that if we are going to be successful in our ability to provide this care. It's interesting. I participated in a payer discussion with 6 national payers. It was a 4-hour session one Saturday looking at coverage determination and why certain procedures should be removed from the experimental investigational determination. And it was one of the nasal obstruction procedures that we alluded to, nasal valve. And one of the most compelling data points from the insurance perspective was also the Epworth Sleepiness Scale score reduction, which is a secondary endpoint that one might not have anticipated. And so a lot of the insurance panels and the people that we talk to are non-otolaryngologists. So they don't understand well the nuances of nasal obstruction, nasal valve collapse, turbinate hypertrophy, vasomotor rhinitis, and the like, or the disease burden that goes along with that. So the better we are prepared with data, with epidemiology, and most importantly, I find in the last few years, the quality of life instruments that we use, SNOT 22s, nose scores, and the like, those are extraordinarily helpful because we all know that symptom scores for these conditions for patients are particularly high and can be higher than other chronic conditions, including hypertension, diabetes, and cardiac issues. So demonstrating substantive, 1, quality of life improvement, 2, cost of care reduction that is profound with safety, efficacy, and durability really makes for a compelling argument. And it's difficult to refute that.
And so, like for your example of your 4-hour discussion with these payers, so at the end of that, the device or the procedure is determined to be no longer investigational, and then it's covered, and then everything's great. What happens next?
I wish it were that easy, right? So one of the payers reclassified the procedure with a favorable determination. The others, about 9 months later are still in review. What we've also been able to do through this past process is have conversations about individual patients. And I think that is also helpful, where we may not have been able to completely reverse the individual policy decision on a particular procedure. When having an internal review on a patient-by-patient basis, we have been very successful in that regard. And I think that's been probably our most helpful strategy at the local level.
Okay. And, thinking about these payers that are still, thinking about it for 9 months after your discussion, and, you were able to prove the cost effectiveness and the durability and that it's better. Like, what do you make of that? Like, what's there to still talk about 9 months later? What's the hesitation on the part of the insurance companies?
I think they look at cost of care. And frankly, this is an ability to deny payment. And in an environment where medical loss ratios and access to insurance, cost of insurance, etc., is challenging, I think at one level it really comes down to, in my opinion, denial of payment, and which unfortunately is denial of care, denial of access, and that extends to not only the kinds of things that we're talking about, but more complex conditions that harm patients ultimately. And so I think the problem is it becomes a war of attrition. And many physicians at some point will say, look, I've tried, I can't do this any longer because the inability to provide clinical care, I will go to option B, and the insurance companies win in that regard. And that's the challenge. A lot of patients, depending on, it's obviously market specific, when they understand the challenge and the denial, will be amenable to paying out of pocket, which in many circumstances for the procedures that we are talking about is still a more cost-effective and affordable option than paying a hospital or other copay and, insurance related to anesthesia, hospitalization, and so on. So the self-pay route is still an alternative, but it's very market-specific as well.
Yeah. Several times you've brought up the internal review process versus independent medical review or external review. Can you just kind of talk a little bit about the differences between those review processes?
Sure. So internal review, for the most part, is a panel set up by the insurance company. And one thing that is helpful is to know what that process looks like, because most of the time one is talking to a retired non-otolaryngologist who, again, doesn't have the expertise to specifically address the patient's concern in a meaningful fashion. So I always request a otolaryngology active surgical peer-to-peer review if possible, and most often it's not possible. And so if failing the internal review process, there is the independent medical review process that can be facilitated through the Department of Insurance. There's no cost to the physician or the patient. And the idea is that it's independent, external, objective, etc. But I think if whatever the review process, trying to get as close to an otolaryngologist that understands what you're trying to do and the problem you're trying to solve for is helpful and important.
Mm-hmm. Yeah, so you should, if possible, you want to request independent medical review from an external body.
Absolutely, and that's where involving the state insurance commissioner is helpful, legislators, primary care docs, and, we CC as many individuals as we can. As I said, insurance companies don't like negative publicity or exposure. And depending what the issues are, some of the insurers in our region have had difficulties with certain hospitals, and the hospitals run extensive media campaigns. And so, to the extent that we can do something in a limited fashion, in a similar fashion, we do that, and they can be effective. Advocating consistently on the patient's behalf is generally a winning solution.
And as far as, appealing these denials, other than what we've already talked about, are there other processes to be aware of?
Other than internal review, external review, and coming back to the insurer, nothing else has been demonstrated to be significantly successful or cost-effective, because one can make a full-time occupation out of this. And as it is, most offices have had to demonstrate significant resources in this process. And it's physician time and it's other FTEs that have to commit to the process. And it really just adds to the cost and complexity of the care.
Yeah. Speaking of resources, so for a practice like yours, you said you're about to have 10 physicians, 18 APPs. What percentage, how many FTEs do you have for this, type of, to do this work for a group that size? Like, is there a ratio that in general per physician or per provider you need, this much work?
So I don't know for the PA, the prior auth, what that FTE ratio looks like. We have all the ancillaries and an ASC, but when you consider the size of our practice, we have 155 staff. Our RCM PA team is approximately 12 individuals. So that's not insignificant. That's not quite 10% of our staff. But I think unless you commit the resources, an RCM efficient practice is essential. And unfortunately, prior auth and those procedures are an important part of the RCM effectiveness. And really, managing AR and everything else aside, if you can't get patients in the door to undergo treatment, AR becomes a lesser and smaller problem to have to deal with, unfortunately.
That's right. For establishing that medical necessity for prior auths, do you use any sort of forms or, patient handouts to kind of help make sure you're asking all the right questions of list, for example, list all the nose sprays that you've already tried for this, or, what treatments have already been done, just so that you're making sure that that's pulled into the record? Or do you just, ask that during your visit and document it in your note?
So we have regular APP physician meetings where I think educating the clinician team on these issues is very important. So everybody knows what appropriate documentation and medical necessity should look like before we go the route of internal and or external review. Our RCM team will have reviewed the records to be sure that we have internal compliance with what it is we're trying to achieve, and then pull together those packages. Industry and vendors and drug and device manufacturers are another important resource here. They all have departments and staff that'll assist in that predetermination, prior authorization, denial process. So, we've developed internal resources, documentation, manuscripts, ladders, and so on. And similarly, the drug and device manufacturers have committed substantial resources to providing similar materials. And so physician practices should always check with those entities to be sure that they've exhausted any options available to them.
Yeah. And so, for example, they're going to tell you, hey, you need to make sure you include, it's not 22, or that, these are certain things that are going to be expected to be able to meet that medical necessity.
Absolutely. And for example, for the SNOT-22, for patients who've undergone similar treatments, to be able to demonstrate to a payer substantial clinically significant improvement in these outcomes at a profoundly lower cost of care with substantially earlier return to work, less secondary care, less episodes of care, and an improved patient journey tells a compelling story.
And so are you keeping track of all of your, personal outcomes to be able to use as additional data? Because you have the formal studies that show their outcomes data. And then are you also able to say, I've been able to take care of 100 patients in the last year, and this was their pre-op or pre-procedure quality of life, and now they're here. This is my personal experience.
Absolutely. And to that point, it's all about the data and being able to manage the data. And we've developed a robust data warehouse and, can develop any number of reports in real time speaking exactly to that. What does that SNOT-22 look like? How many visits has this patient had? What's their, pharmacotherapeutic use over time? How has that changed? So any and all of those tools are really helpful in having the conversation. And despite how logical and how patient-focused the discussion may be, there are times when you just cannot win, but you cannot stop fighting.
Yeah, that's the hard part, right? It's just kind of getting beaten down and worn down with all of the denial and feeling like, what's the point? What's the incentive? So it's good to be reminded and to be, encouraged along to keep fighting the good fight, right?
Right. And I think, we're fighting the good fight on behalf of the patient, the things that we consider important in our practices and for us to continue to practice. And ours is a field that is so diverse that there are so many different opportunities for drug and device development and innovation that if we can't do this and don't advocate on behalf of the patient and the technology, the interest in R&D in otolaryngology, head and neck surgery will dwindle, and we won't have these opportunities going forward. So, I think circumferentially, there's an argument to be made all around about why this is so important.
Yeah, I think there's so much to it as we've kind of discussed in the last hour. But the key take homes are that we need to engage our peers and partners who are working as medical directors in these payer systems and have those conversations, advocate for our patients, encourage our patients to advocate for themselves, and to just keep chipping away at it, right? Little by little, just keep on building a case to be able to use this new technology to be able to provide, better patient care and care that's kind of on the cutting edge to keep on, doing better.
Absolutely. And working together with colleagues in the region, at the national level, the academy, specialty societies, legislators, drug and device manufacturers, bringing the full power of advocacy to the patient.
Yeah. So for the practices that are smaller or solo, I think it's definitely important to remember the power in numbers, even just as a collective, as an, otolaryngology group at large. There's resources with the academy, resources, within state associations and societies, and to not try to feel like you have to take on all the burden alone and not trying to recreate the wheel because it exists.
Absolutely. And to your point, using those resources simplifies the process, not recreating the wheel or wasting resources in that time frame.
Yeah, because our time is precious and valuable, and it's not like we have a lot to spare with all the other things you're juggling with practicing. So
absolutely, and being mindful of work-life balance and trying to limit the potential for burnout in an environment that is quite challenging. Yet the joy of providing this kind of care and using these innovative opportunities really guides the future for us.
Yeah. Yeah, I really appreciate you taking the time to go through this today. I think it's very easy to feel overwhelmed by, trying to navigate the health insurance landscape. And I feel more hopeful after talking to you about it. I appreciate you creating a bit of an algorithm or a rubric for how to navigate the complexities and kind of breaking it down and simplifying it. It's a little less intimidating after kind of talking it through. So thank you for taking the time. Is there anything else you would like to leave our listeners with as we round things out?
Well, thank you, Ashley. This was a great opportunity, and I greatly appreciate the opportunity to participate here. Just use the resources available. We're all fighting the same fight, and I think together we can lean on each other, lean on the other entities available, providing resources, and we'll get the job done.
Yep. Don't give up.
That's it. Continuous, never-ending improvement, as Robbins would say.
I love it. Well, thank you so much. Listeners, if you want to reach out to Gavin Setzen or learn more about his practice, he's at Albany ENT and Allergy. Are there any social media plugs or handles you want to throw out there?
Well, we have our website is www.albanyentandallergy.com, and I'm certainly, LinkedIn and other social media platforms, and would be glad to connect and communicate with any of your listeners, and as we face similar challenges ahead.
Wonderful. Thank you so much.
My pleasure.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ENT on Instagram, LinkedIn, or Twitter. BackTable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening, and see you next week.